continue. This one, I believe it's a Zoom with Dr. Kamperou, who will present the role of preoperative cardiac MRI in congenital pulmonary valve anomalies.
Thank you for the opportunity to participate in this effort. My name is Dr. Kamperou. I am an imaging cardiologist. I will comment today on the preoperative cardiac MRI in congenital pulmonary valve disease. Let me share my PowerPoint. Share. Okay. Can you see the PowerPoint at all? Okay. All right. Following the excellent anatomic and echocardiographical presentations earlier, it is useful to briefly revisit the spectrum of congenital. Let's see. Yes. Of congenital abnormalities affecting the pulmonary valve complex from an imaging perspective. These conditions span from a wide anatomical continuum, ranging from simple tract narrowing to complete anatomical discontinuity between the right ventricle and the pulmonary circulation. A central reference point within this spectrum is the trilogy of Fallot. In its classic form, the condition. Sorry for the pop-up. The condition must be carefully distinguished from pulmonary atresia with a VSD, which represents a more severe end of the same spectrum, and pulmonary blood flow is frequently supplied through major pulmonary collateral arteries. Accurate identification, characterization, and mapping of these collateral vessels is one of the most important contributors in preoperative cardiovascular magnetic resonance, as this information directly informs surgical strategy. Another important entity is pulmonary atresia with intact ventricular septum. In contrast to the trilogy of Fallot, the absence of VSD prevents the compression of the right ventricle during fetal development. As a result, the RV is often severely hypoplastic, raising a critical surgical question whether the right ventricle is capable of supporting biventricular circulation or whether a single ventricle pathway, Fontan circulation, is required. Finally, absent pulmonary valve syndrome represents, sorry for that, I have a problem of a hiccup with my, can you see my PowerPoints?
Yes. Yes, we see.
Okay. Represents a distinct pathophysiology scenario. The absence of functional pulmonary valve leads to severe pulmonary regurgitation and massive aneurysmal dilatation of the pulmonary arteries. Importantly, this condition extends beyond the cardiovascular system, as you can have compression of the tracheobronchial tree. The aim of this presentation is therefore to explore how cardiovascular magnetic resonance can provide a comprehensive anatomical and functional roadmap, enabling precise characterization of these complex RVOT lesions and supporting optimal preoperative decision-making. CMR allows precise characterization of the RVOT and pulmonary valve anatomy, accurate measurements of the pulmonary annulus, the RVOT geometry, and the proximal pulmonary arteries, guiding surgery in selecting the appropriate conduit or valve size and planning the reconstruction strategy. Another crucial aspect is coronary artery anatomy, and CMR is also extremely valuable for evaluating the pulmonary arteries and collateral circulation. Three-dimensional echoangiographic datasets allow comprehensive mapping of the branch pulmonary arteries and the major aortopulmonary collateral arteries, which is fundamental when planning unifocalization procedures and pulmonary artery reconstruction. Finally, CMR provides insight into the biological state of the myocardium by assessing regional ventricular function and identifying fibrosis with late gadolinium enhancement. We can better understand the degree of ventricular remodeling and guide the timing of intervention before irreversible dysfunction develops. In this way, CMR does not simply describe the anatomy of congenital RVOT disease, it provides that information that ultimately shapes the surgical strategy. Echocardiographic remains the first-line modality, but there are significant limitations, especially in the follow-up and older populations. The RV has a highly complex geometry. Echo measurements often rely on simplified geometrical assumptions, such as ellipsoid or pyramidal models, which become inaccurate in the presence of RVOT dilatation or RVOT aneurysms. In addition, many congenital patients have limited acoustic windows after surgery, further reducing measurement reliability. CMR overcomes these limitations because it does not rely on geometric assumptions. Instead, it uses a stack of continuous scene images that cover the entire right ventricle, allowing true volumetric image reconstruction. Using steady-state free precision sequences, CMR provides excellent blood myocardium contrast and very clear delineation of the endocardial border. As a result, RV volume measurements are highly reproducible with low inter-observer variability. This is clinically crucial because indexed parameters such as end-diastolic and end-systolic indexed volumes are now key metrics used to determine the optimal timing of pulmonary valve replacement before irreversible RV dysfunction develops. As you can see here in these 3D SSFP images, CMR embraces the entire RV by utilizing a stack of continuous slices. It is very important in congenital cases because where we can encounter frequently outpouching or aneurysms of the RVOT, abnormal anatomies, and it provides high signal-to-noise ratio, excellent blood myocardium contrast, and allows true 3D reconstruction. CMR has been increasingly used, has a central role in finding the optimal point for reintervention, and new MR techniques have developed encompassing 4D flow, speckle tracking that can help provide more accurate, more refined indications for reoperation and interventions. And another vital component is the mapping of the coronary arteries, especially when anomalous coronary arteries coexist, where we can have catastrophic coronary laceration during RVOT incision, and this is an anatomy that you need to know before you go to the operating theater. The SSFP sequences define anatomy. Phase contrast imaging provides the hemodynamics, allows to quantify the workload on the right ventricle. The workhorse sequence for flow assessment is phase contrast sequence, and the commonest example is pulmonary regurgitation. With through-plane phase contrast imaging positioned perpendicular to the pulmonary valve, we calculate the regurgitant fraction by integrating forward and reverse flow throughout the cardiac circle. And secondly, we can implement phase contrast imaging in the branch pulmonary arteries, allowing us to assess differential pulmonary flow. Normally, we expect roughly a 55 to 45% distribution between the right and left lungs. Marked asymmetry suggests branch pulmonary stenosis and has important implications for intervention. And finally, peak velocity of the RVOT allows estimation of the pressure gradient across the structure for any obstruction. It requires proper setting, proper vent, and in order to avoid aliasing or loss of velocity sensitivity. To understand the true surgical potential of the right ventricle, the portent of recovery, we must look beyond size and evaluate the tissue characteristics of myocardium. CMR allows this through tissue characterization and myocardial deformation analysis. LG enhancement identifies focal fibrosis, in which repaired tetralogy of Fallot can be located in the RV septal hinge points and surgical scars. These scars are normally increased focal footprints. They can form the substrate for ventricular arrhythmias and have important implications for risk stratification and ICD decisions. On a more subtle level, T1 mapping and ECV quantify diffuse interstitial fibrosis, reflecting chronic remodeling and reduced myocardial compliance. And feature tracking detects early RV dysfunction before ejection fraction declines. And together, these techniques can distinguish a ventricle that is simply small from one that is biologically incapable of sustaining a biventricular circulation. 4D flow, while 2D phase contrast CMR is the reference method for calculating recurrent fraction, 4D flow provides a deeper understanding of right ventricular workload. The entire RVOT and pulmonary arteries are acquired in a time-resolved 3D dataset. Analysis planes can be placed retrospectively and valve motion can be tracked through the cardiac circle. This slide demonstrates how phase contrast CMR and 4D flow can be used to assess PR after repair of tetralogy of Fallot. In panels A and B, sagittal and coronary views of the RVOT are used to position the imaging plane perpendicular to the pulmonary artery, and correct plane alignment is critical to ensure accurate through-plane phase contrast flow measurements. And in panel C and D, phase contrast CMR provides quantitative flow analysis, and after segmentation of the pulmonary artery, the time flow curve shows forward systolic flow, followed by significant diastolic reverse flow, which is the hallmark of the PR. And panels E and F illustrate the same physiology using 4D flow CMR. And so these flow planes can be positioned retrospectively and tracked through the cardiac circle. So this approach allows for comprehensive visualization and precise quantification of the pulmonary recurrent volume and fraction, key parameters that guide the timing of pulmonary valve replacement in repaired tetralogy of Fallot. Beyond simple flow quantification, it also enables the assessment of energetic biomarkers such as turbulent kinetic energy, viscous energy loss, voricity, and wall shear stress. These parameters can identify inefficient flow and increase the ventricular workload, potentially identifying maladaptive hemodynamics before conventional volumetric threshold for intervention are met. Now, in the pediatric population, there are several considerations that need to be taken into account, both regarding the patient management and the imaging technique, which must be both adapted to the patient's level of age and patient's age and level of cooperation. So for school-aged children, typically from the age of 6 to 7 years, CMR can be performed without sedation, especially with audiovisual distraction, such as music or movies. And infants and very young children, cooperation is limited. So sometimes a feed and wrap technique can be used or mild sedation. For longer, more complex protocols or when close hemodynamic monitoring is required, general anesthesia may be necessary. And practical consideration during pediatric scanning is sequence prioritization. So the most clinically important sequences should be acquired first in case the examination needs to be stopped. And it has also been shown that when it is performed with precautions, it is safe also to perform in patients in children with pacemakers and ICDs at 1.5 Tesla, following established safety protocols. Also, there are several technical adaptations that need to be made. The deep learning acceleration cine techniques and free breathing techniques, they need to be implemented. So here we demonstrate the improvement in border definition achieved with deep learning reconstruction. And here is a list of resources and further reading recommendations. So in conclusion, CMR provides a comprehensive evaluation of anatomy, ventricular function and flow in congenital pulmonary valve and RVT disease. By integrating these parameters, it plays a central role in guiding surgical planning and optimizing patient outcomes. Thank you for your attention.
Thank you. Thank you so much, Dr. Kamperou. Now I would like